Well, hello, Dr. Cabiling. Thank you so much for being here to have this conversation with me. I've been really looking forward to seeing and hearing and asking you questions and just having this nice conversation. And I just want to let my audience know that I came upon you and the Center for Restorative Breast Surgery. Actually, a little birdie told me about the center back in a year ago, I would say July, when I had just been diagnosed. I was just starting my chemotherapy, and it sort of wasn't on my radar about breast surgery yet because, well, I just wasn't thinking about it. And then fast forward a few months later, after I finished chemotherapy, I had literally two other people, completely separate people, reach out to me and say, "Hey, my sister-in-law or my friend had this surgery at the Center for Restorative Breast Surgery, and you should really look into it." And I had never heard anything really about it. So that's when I first started to have that on my radar and started really doing some research. And I will tell you that going and having my surgery done at the center in New Orleans with you and Dr. Wright, I will say in many ways saved my life. And I get really emotional about it because it saved my life emotionally and really even physically, because I was able to, I call it kismet that I actually came upon you guys. And so welcome. I'm so thrilled that you were here. How are you?
I'm great. Thank you so much for reaching out and setting this up for us to have an opportunity to chat a little bit about your experience and sort of some of the things that we do here in New Orleans at the Center for Restorative Breast Surgery. Um, I think it's a great opportunity to hopefully provide a little bit more information and hopefully educate some folks about some of the things that we do and maybe some of the things that we do different, and hopefully be able to reach out and help a lot of women in need.
Great, great. Well, that's what we need, because I will tell you that no one here in Reno that I knew of, except for one person that told me, knew about this kind of surgery. And it's really, I know it's the autologous surgery, and in particular, the DIEP Flap surgery. Um, can you just, before we get into major questions, kind of tell us a little bit about what drew you to surgery and this particular type of surgery?
Yeah. I think like a lot of folks that end up doing sort of very subspecialized components of medicine, what drew me into it was twofold. One, it was mentors that I was just very lucky to run across over the course of my training of many years to get here, and finding surgeons that were teaching me and taking care of patients and doing work that I found was just quite amazing, and saw that they enjoyed it. And it's something I've been very fortunate myself to have that same experience. I really love what I get to do. It is the best job in the whole world, for me. I just enjoy the work we do and delivering the experiences and the benefit to our patients, and seeing stories like yours in terms of the taking patients from a time of need and bringing them to a much happier place and feeling whole and restored after a difficult cancer journey. And then really seeing the major benefits that the work that we do can impact on patients. So enjoying the work and seeing the massive benefit really was just a good fit for me, to eventually come to being a very specialized plastic surgeon doing microsurgical breast reconstruction for um, for what I do in my career.
Well, I love that. And you also have the personality to go along with it. You have a very good bedside manner. I can attest to that. And it's a very human story that we're talking about here.
Yes.
And so thank you for doing what you do. So many people do not even know what autologous surgery is for breast reconstruction, and in particular, even what the DIEP flap surgery is. I know that you take tissue from other areas, and I'm just talking about that because that's what I had. So can you kind of give us an overview of what autologous surgery is, and then kind of into the DIEP flap type surgery?
Sure. So women facing breast cancer, and then in particular a mastectomy, the sort of the flip side to that is going to be the discussion about what their reconstructive options are. Um, and so conceptually, a breast reconstruction following a mastectomy is a relatively straightforward idea. The idea is that the mastectomy surgeon is going to come in and remove all of the breast tissue, including the cancer, leaving essentially an empty envelope of breast skin that needs to then be filled with some sort of technique. Women that meet with me, we talk about all of the options that might be available to them. And those options can be an implant-based reconstruction, or the alternative, which is an autologous tissue reconstruction. The goal is to then fill or replace the missing breast tissue with one or a combination of those techniques to replace the missing breast tissue. Far and away, the most common method of breast reconstruction performed is going to be an implant-based reconstruction. It's just going to be much more available to patients when they're seeking out care providers, in particular reconstructive surgeons, to provide that service for them. An implant reconstruction is going to be much more available to them in comparison to what you and I ultimately decided on is an autologous reconstruction. So
that's how you pronounce it. Thank you.
Autologous meaning coming from your own body.
Okay.
So instead of using an implant to replace the missing breast tissue, which can work very well in the right situations, the alternative is to use your own tissue. And in my opinion, for the right patients, I would consider that to be the gold standard for that. And it makes the most sense to me. We're removing tissue from your body, and therefore the reconstruction in an approach that replaces missing tissue with living tissue from your own body seems to be the best approach for it. And that's what an autologous reconstruction does. The breast tissue is removed, and then it is replaced not with an implant, but with tissue to replace the missing breast tissue from a distant location on your body. And there are a number of locations that can be borrowed from, what are called the donor site, meaning the place we borrow the tissue from to then use to replace the missing breast tissue to do and perform the reconstruction. There are a number of well-described and popular donor sites or places to borrow from, but the most common, at least in our hands, would be your lower abdomen, which is then termed a DIEP flap. And we can talk about where that terminology comes from. But the idea is essentially to sort of convert the lower tissue, skin and fat of the lower tummy that would be very similar to, say, if we were to meet for a tummy tuck, and convert that into the material we use for a breast reconstruction, and therefore replacing the missing breast tissue with living fat and skin from the lower tummy to restore the breast, and then providing a firmer, flatter tummy, very akin to a tummy tuck, all in one complete operation.
What a deal. So that's what so I mean, I joke around, and it's really not a joke, but with other cancer survivors about how people actually say, "Oh, good, you get to go have a boob job and a tummy tuck and all that." It's like, yeah, that's not exactly what I wanted to do,
No.
but it does make it so, it just kind of makes it a little bit better, to be able to do all of that at the same time.
Yeah,
I know that.
Get a significant for that overall.
Can you say that again?
Yeah, no, I think our patients really gain a significant benefit. Sort of puts a positive spin on the whole journey that they're going through for their cancer care, that they can kind of look forward to, some restorative surgery to make themselves feel whole again. And then maybe, we try to consider the overall aesthetics of all of that. And hopefully we can deliver a result that is an improvement in sort of your self-body image following the mastectomy and the cancer reconstruction.
Yes. So the DIEP flap, what I had, what can you tell us about that?
So I would say that's probably our workhorse of autologous breast reconstruction. It is a well-described operation that we have a lot of experience with here at the center. The idea is, as I mentioned before, to take skin and fat from the lower tummy and transplant it to the chest to restore and replace the missing breast tissue. The operation is a microsurgical procedure, and what that means is that we utilize the assistance of high-powered magnification through a microscope, a surgical microscope, to be able to perform these operations, because the sort of the crux of the procedure is that the tissue is coming from one location, either your tummy or another donor site, of which there's a number of other ones for patients that may not be a candidate for a DIEP flap. And then taking that tissue, transplanting it to the chest, and allowing that tissue to still be alive. For tissue to still be alive, it requires that its blood flow still be intact, and that's where the name of the procedure comes from, related to the blood flow to it. And the microsurgery portion of it has to do with, we reconnect the blood flow, small little arteries and small veins that we carefully keep intact with the tissue that we're using for the reconstruction, back to the chest vessels or chest blood flow to maintain its new blood flow in the new location on the chest. So the procedure is to harvest the tissue, keep the blood vessels attached to the flap or the material of skin and fat that we're using for our reconstruction. We divide or cut the blood vessels so that the tissue becomes completely disconnected from your body. And then it is transplanted to the chest, and then under a microscope, those small arteries and small veins are reconnected into new blood vessels here in the chest, so that tissue then reestablishes a new blood flow here in the chest. And then we have living tissue that can be then molded and sculpted into the new breast mound to recreate the new breast made of your own living tissue. The benefits of that are many, but among the top ones that I would usually quote to patients is that it feels the most natural. It makes the most sense because it's made of the same stuff that breast tissue is in terms of, the living fatty tissue. It tends to be the most comfortable for patients. A lot of the work we do is removing uncomfortable implant reconstructions and replacing it with our own tissue. And then a big one for a lot of folks is that it's permanent. And we can talk a little bit about implants, but implants in general, I don't think of as a permanent, lifelong situation. They are a medical device to which they eventually will wear out or develop some issue or problem, most likely requiring patients to have some kind of upkeep to them, either an exchange or a replacement of the implants sometime down the road for them. Whereas an autologous reconstruction kind of ages very gracefully and ends up being a permanent, natural reconstruction for patients. Why I consider it sort of be our gold standard for that.
Well, being many months down the road, I had my surgery last December. I can attest to they do feel very natural. It's my own skin, and they just feel very natural. You kept them the same size as they were before, which is really cool because I didn't want to go bigger or anything like that. But but in a perfect world too, the DIEP flap or any of those surgeries, I'm not sure, but in a perfect world, there's a phase 1 and phase 2. So my understand.
Yeah, exactly. So here at the center, through many years of experience of doing these types of procedures, from the get-go, we try to set out a plan, a surgical plan, and sort of an expectation of the journey that the surgeon and the patient are going to take together, in terms of where we're starting and where do we ultimately want to envision our result. And that typically involves more than one step to achieve that goal. And so from the get-go, we try to explain that our approach towards our breast reconstruction to achieve our best results and our vision of what our result is going to be is that it's going to be in typically 2 parts. The first surgery is what we call phase 1, which is the procedure we just talked about in brief, which is the complex microsurgical procedures where we're transplanting tissue from one donor site to the breast, reconnecting blood vessels under a microscope, and then reshaping a new breast from living tissue from another donor site. We usually like to let that heal for a number of months. Minimum of approximately 3 months would be a general estimation for most patients. And then reevaluate what result we have from that. That typically gets us very close to the end result that we're looking for, but we do know that there are oftentimes some small tweaks and adjustments, minor symmetry corrections that we can apply to our first stage result to further optimize the result to get to that final outcome that we're looking for. And that's what our stage 2 procedures are. There are minor tweaks and adjustments to that living reconstruction to ultimately get to the desired result.
Which is what I'm looking forward to that.
Yeah. Additionally, sometimes ladies are looking for a big change overall aesthetically to their starting, from what their starting situation is to what they envision. And sometimes that can involve a significant breast lift or some other aesthetic improvements to their overall result. And we can do those. It's one of the benefits of having a living tissue reconstruction is that I can oftentimes apply many of my normal aesthetic cosmetic breast surgery techniques to the result after phase 1, because that result is a living part of your body. It is a living breast reconstruction. And so I can apply many of my normal breast lift techniques or other surgical procedures to that living breast reconstruction to take it to the next level in terms of the overall result. Those techniques are generally not as applicable to an implant reconstruction where the breast is essentially 100% implant covered by the mastectomy skin. An autologous reconstruction has the advantage of being living tissue with living skin, that then we can do some of our normal cosmetic surgery techniques to deliver some of the better results.
One thing I really love about the surgery that I had is that it didn't compromise the muscle. That is huge.
Yes.
I feel like it's definitely a shorter recovery time, which I want to get into. I've actually had some audience members who've reached out to me and said, "Hey, can you ask some of these questions that I have next?" One is the expectation, like what is expected for recovery time with these surgeries? And I know they're all different according to whatever kind of surgery you get. And we can talk about DIEP Flap specifically, but what are we looking at as far as recovery time? I'm okay now, like I'm all healed up and I actually healed pretty well. But what is the typical, what do you have to say about that?
What we usually recommend to patients in terms of their expectations coming into this for a mastectomy with DIEP Flap or a delayed reconstruction, say someone had already had a mastectomy already, healed from that, now is looking for breast reconstruction, but recovery from a DIEP Flap, either one or two sides, typically probably in the 4 to 6 to maybe 8 week range in terms of the time off from work if you have a more physical type of job, and overall recovery in the 4 to 8 week range would probably cover most patients for that. The question that you mentioned in terms of the muscle, that has been sort of the evolution of this procedure and sort of the development and the refinement of the procedure over the years. The grandfather to the DIEP, the original idea, comes from a procedure called the tram flap. And the tram flap was the idea of borrowing the skin and fat of the lower tummy to restore the breast using your own tissue. And that was a great development in the overall process of breast reconstruction. But the procedure did have some downsides. And the downsides were that the skin and fat that we need and the blood vessels below that allow the perfusion and the nutrition and oxygenation of that tissue so that it can be transplanted happen to be separated by your six-pack muscle in your lower tummy. And so the original procedure would sacrifice the muscle because the two structures we needed, the blood vessels and the skin and fat, had the muscle in between them. And so it had to be cut and damaged or sacrificed in the pursuit of transferring that tissue. And so the evolution, realizing that the muscle sacrifice did have morbidity to patients and did cause pain, discomfort, weakness, bulge, occasionally hernias in ladies that had had those procedures, was an evolution to minimize the donor site compromise. So to minimize the damage to the muscle as we went through. And so there has been an evolution over the number of decades since the original tram flap was developed to taking less muscle, what's called a muscle-sparing tram, which still sacrifices some degree of muscle. And then the next big jump was to do the DIEP Flap. And the DIEP Flap is a procedure where we spare the entirety of the muscle, being able to take the blood vessels and the skin and fat that we need to be able to perform the procedure, but leaving the muscle intact. And that's what I would think the modern version of those procedures should be.
Good. And we were pretty close to losing access, a lot of us losing access to that surgery. And thankfully, CMS made the decision that they did to keep the DIEP.
Thanks to everyone that came out to advocate for that. The two procedures are completely different. A tram flap and a DIEP flap are orders of magnitude different. They look the same potentially from the outside, incisions and the concept of transferring that tissue, but the actual performance of the procedure and then the benefit to patients of maintaining the integrity of your core muscles in your abdomen are vastly different procedures. And so I think there was a misdirected adventure by CMS to combine those two together and say they were equivalent when they truly aren't. And so that was a very
scary
event, but fortunately we came out on the right side of that.
Yes, I found out about it after my surgery, and I jumped right into that advocacy work. And so I'm so glad I found out about it.
That advocated for that as well,
Yeah. So so some of the other questions I have, I know that some women want to keep their nipples, and I didn't, and it didn't matter to me. It did at first, but then I was like, but nipple sparing.
Yes.
What is that? What's entailed with that?
So nipple-sparing mastectomy, again, it's sort of the same story I was mentioning as the evolution of the procedures for reconstruction of breast cancer has been to minimize the morbidity and sort of preserve as much of the natural structures as we can in an effort to minimize the downtime and the discomfort and the recovery and maximize the overall results. The same evolutions happen in terms of sort of breast cancer care and mastectomies, from the original radical mastectomies all the way to skin-sparing mastectomies and now nipple-sparing mastectomies. The idea is that we can preserve as much of the natural breast as possible without compromising the oncologic safety of the procedure. Mm-hmm. And so originally it was thought that the nipple had to be removed as part of the mastectomy to perform an adequate cancer operation and provide the best results from that. But over time, it's been demonstrated and shown that we can, in many, many, many patients, save the nipple as part of the mastectomy and really just remove the internal breast tissue, but preserve the outer skin of the breast, and what we also call a total skin-sparing mastectomy. So it's preserving the entire external surface skin of the breast, such that when we go back to do our reconstructions, we're just filling the internal component, but externally, all of the natural breast skin is preserved. And so our mastectomy surgeons here at the center are well-versed and are experts at performing nipple-sparing mastectomies. And for the vast, vast majority of women, they will be a candidate for that. It depends on the tumor status and location and size. And sometimes, occasionally, that's not possible. But for a good number of ladies, our nipple-sparing mastectomies are able to be performed. And again, our mastectomy surgeons here are incredibly familiar and experts at that procedure. I prefer doing that for a lot of ladies because then when we do our breast reconstruction, the external appearance of the breast is still your natural breast skin and nipple. And so in general, I like to preserve the majority of the natural breast so that we get the most natural results afterwards.
I think, because I have all my own skin.
Yes, so everything on the outside that you see on the breast reconstruction is your natural breast skin. Yeah. And when that's possible, I think that delivers, what our best outcomes can be. Occasionally, ladies don't have that ability. They've had a mastectomy before and are coming for a delayed reconstruction. Sometimes they've had radiation and the skin of the chest is very tight and firm. And in those situations, we do need to replace the skin on the outside of the breast to create the natural curvature and shape. And we don't have the envelope to fill, but we need to recreate that. And that's what we call our delayed reconstructions, or coming after the fact. And those can still be very, really quality results with really fantastic outcomes in those situations too. And then there are always options for nipple reconstruction for ladies that either chose not to save their nipple or weren't candidates for it and weren't able to. And so we can come back at stage 2 as part of that secondary touch-up revision surgery and do nipple reconstructions and sort of restore all components of the breast and create a complete breast reconstruction.
Fascinating. I've seen a lot of pictures, and I just want to point out to my audience that the website for the Center for Restorative Breast Surgery they're going to be in the show notes, and people can go to the gallery and look at a lot of different before and after
I think
pictures.
our before and afters encompass a good range of different body types and different situations, from nipple-sparing immediate reconstructions to ladies that have had mastectomies and radiation before and then have a full delayed reconstruction, or other situations that come in. We have a diverse experience of seeing many situations and ladies at different stages of their reconstruction. And I think we have expertise to be able to take you from whatever situation you're at to the goal and desired outcome that you're looking for.
Wonderful. Numbness. I know that many women have to sort of understand that things might not feel the same. That was one of the biggest issues for me, but I am getting some sensation back in parts of the breast. And so with numbness, I would say that, is this a long-term thing, a forever thing, or does it eventually come back, or how does that work?
I think that's another advantage of an autologous reconstruction that I didn't mention before, is that by providing the new breast with living tissue that is your own body, the nerves that are cut as part of the mastectomy that provide the sensation to the breast, they have the ability to regrow through your own tissue and provide some reinnervation and restoration of some of the sensation, as you are describing for your own self and experience, that you're getting some of that back. That process is slow, however, and so I usually tell patients to think about the body's ability to regenerate some of those nerves back into the new breast reconstruction over a period of probably about 2 years. And so it's not an immediate result that you'll have restoration of some sensation, but it is much more likely to happen in an autologous reconstruction than it is an implant reconstruction. Whereas a nerve cannot regrow through a silicone or saline breast implant, it can regrow and reconnect to your own tissue and provide some of that sensation restoration. But to the point of expecting full normal sensation after a mastectomy and reconstruction of any method, unfortunately, patients should expect to have some reduction of sensation initially. With an autologous reconstruction, you can expect to have better improvement probably over time. And I think one of the advantages of having your own tissue as the method of reconstruction versus an implant.
Right. This is one of the questions I wanted to ask later on, but about lymphedema. I didn't realize this, but you know a lot about living with lymphedema. How do you all make the decision about how many lymph nodes to remove during surgery? I know that I had 3 on one side, on the breast cancer side, and 1 on the other. How did you and Dr. Wright make those decisions?
Yeah, that's probably the decision that I usually defer to the mastectomy surgeon who is doing it. But typically for the invasive cancers, the ladies that have an invasive ductal or invasive lobular type of cancer, when they sample the lymph nodes for the sentinel lymph node biopsy, I think the standard is to take more than 1 when available, to make sure they get a good sampling and therefore a good evaluation of the lymph node status on those. So you had 1 or 3 lymph nodes removed on that side. That would be pretty typical for our breast surgeons when they're doing a sentinel lymph node for a cancer, to make sure that they have a good sampling to ensure that the staging of the patient is accurate, so we know that the lymph node status is correct, which then directs further adjuvant therapies in patients in terms of potential chemotherapy afterwards, potential radiation afterwards. A single lymph node might be done in situations where there's less aggressive disease or less concern over spread to the lymph nodes in those situations. But I would say very commonly we see three lymph nodes sampled as a baseline for patients with a invasive cancer on that side.
Okay.
Patients that then maybe have a positive node or disease spread outside of the breast to the lymph nodes, the typical situation would be for that breast surgeon then to evaluate further beyond those 3 nodes and take out additional lymph nodes from the axilla or the armpit area, to make sure that there's not spread beyond those first 3 lymph nodes into further lymph nodes. So again, we can have accurate staging and accurate decision making in terms of what the best cancer care might be afterwards.
Okay, interesting. Thank you for answering that. I want to go back to the decision that people make between implants and like DIEP Flap type surgery. What are some questions that people should ask when considering either one?
I think it's
Because
important.
I know it's very personal for people, and
Yeah.
for me it was very, I mean, for most people it's personal, and everybody, that's, but what kind of questions should they ask?
Yeah, and I think, again, exactly to the point you're making, is they need to have a full discussion with their reconstructive surgeon regarding the options that might be available to them. And everyone is I treat all my patients as a very individualized case and individual decision making regarding that. Not everyone is a good candidate for all the procedures. And so in my situation, when I meet with a new patient coming in with breast cancer to discuss their reconstructive options, we talk about all the options and then the pros and cons of them as thoroughly as we can discuss them. And I think, there's not necessarily a right answer for everyone. Everyone has their own individual factors that go into their decision making regarding that. And, I think it's important to kind of lay out patients' concerns regarding what their expectations are for the surgery and the recovery, the factors that are involved in their lives. Everyone comes to it from a very personalized experience, but I think it's important that they get a full discussion regarding all of the options with their breast surgeon in terms of making those decisions.
Well, that's really the experience that I had with you, is that your philosophy, it seems, on shared decision making is right up my alley for sure, because a lot of times when you are speaking with surgeons or other healthcare providers, they don't really have the bedside manner to have that shared decision making piece about them. And you did. When I first met you was really literally the day before my surgery, and my husband and I had some decisions to make that day based on some things that you let us know about how much tissue I had to pull from my abdomen to reconstruct both of my breasts, because I decided to do both of them. And you laid out some options that we really needed to think about. And you were really good at helping me understand some of the pros and cons. And so I felt like that decision making made me feel better about coming in the next day and going into this surgery. So thank you for being that type of surgeon who understands the emotions that go along with that for women.
Yeah, no, I think the shared decision making that you just mentioned there has absolutely been my philosophy from the very beginning. My approach towards towards new patients and trying to come to a decision on again, the journey that we engage on together about the reconstruction is really to kind of lay out all the information that I can to educate my patients about what they might be facing and what to expect. And say, here's everything that we possibly can do for you. Here's my professional opinion about what I think might be best for you for these reasons. But these are other options as well that we can consider and help you weigh those decisions, because so much about this is very gray. There's not necessarily an absolute right and absolutely wrong answer. I tend to see everything on a spectrum of choices that we make in terms of pros here, but maybe not, maybe some cons. And additionally, on the other side, we can face in making those. And I like to share that decision making with patients and let you kind of into my thinking about what I'm evaluating and the factors that I'm considering and trying to choose what I think is going to be best for that individual patient, and make it very transparent in terms of how we're going forward in that process to figure out what is the best choice among the choices that we have. And so I think one of the benefits of coming to a place like this center is that I'm able to offer you the whole gamut of all options for breast reconstruction. I don't just have one technique that I can offer all my patients and trying to fit everyone into that pot. I can offer you implant reconstruction. I can offer you the entire gamut of all options for tissue-based reconstruction and any combination of all of those. And so very comfortable to lay out everything for patients and help them see the landscape of what choices they could be making and then help guide you through those decisions.
Great. I love that there are those options, and there are surgeons out there such as yourself who are able to lay those out. There are so many women who have not been, who are really not even offered this kind of surgery. This is something that happened to me in my area. We have wonderful surgeons here. We do not have this type of surgery in our areas, which is, a lot of women don't have it in their area. Because it isn't available, what are some of the efforts being addressed to ensure that all women have the option without actually breaking the bank? I know there's different prices according to insurance and so forth. I guess the question I'm asking is, how can we make this open to more people, again, without breaking the bank?
Yeah, and I think some of the things that happened at CMS about maintaining some of the coding components that we just briefly mentioned earlier in our conversation, it was a big step towards that. That would have been a detriment to the access to patients. And I think exactly the work that you and I are doing here in terms of your podcast and educating folks, of letting people know that these things are available, that these choices can be offered to them, and that it doesn't have to be just one option in terms of when you're coming to face a decision regarding the reconstructive surgery that you'll be facing after the mastectomy. I think education and awareness is really one of the biggest things that we're trying to push for, and let people know that there are different methods of reconstruction, potentially better ones for their situation. And that there are surgeons out here available to do those kind of procedures for them.
Well, then I'll keep this podcast going, and thank you for your efforts as well.
No, hopefully we can do that to other folks.
Good. So another question that I thought of, because when I was at the center, you have a therapist there that deals specifically with lymphedema
Yes.
prevention. I never even knew what that was. I know what it is now, and I learned more when I came back to Reno, because we have a wonderful therapist here that I actually interviewed earlier on in one of my earlier episodes.
Great.
It turns out that you are also an expert at helping people live with lymphedema, or even lymphedema prevention, and many women just don't know about it. So what do you know?
Yeah, unfortunately, lymphedema is another component that maybe is not as addressed early on for ladies facing breast cancer, but can be a lingering reminder of their breast cancer after many years afterwards. And so what is lymphedema? Lymphedema is essentially it is the swelling of an extremity because of insufficient drainage of a specific kind of fluid that is produced in our natural tissues called lymphatic fluid. So the natural physiology of our body is that the lymphatic fluid is produced in our extremities and then drains back out of our extremity through special channels called lymphatic channels. And those make little stops to get filtered and check for infections or other issues in terms of our immune system in our lymph nodes, which are in little spots across our extremity. As we were just talking before, a very common component of breast cancer treatment and mastectomy surgery is to sample the lymph nodes of the axilla or the armpit to make sure that the tumor of the breast has not spread to them. To sample them, they have to be removed. And so removal of the lymph nodes can then disrupt the flow of the lymphatic fluid out of the extremity. The risk of developing lymphedema with just a couple lymph nodes removed is quite small. But for ladies that have all of the lymph nodes of the axilla removed, and then additionally radiation, that really can significantly damage the flow of the lymphatic fluid out of the arm. And when the flow is obstructed, the fluid builds up and you get swelling of the extremity. And so that's what lymphedema, particularly breast cancer associated lymphedema is swelling of the extremity, hand, forearm, and arm most typically, due to insufficient flow of the fluid out of the arm because of damage due to radiation plus surgery, and then there are a couple other components that can contribute to that.
Okay.
The therapy for that for many, many years has been conservative, essentially trying to manage the flow, the swelling of the extremity. Those things would include massage to kind of push the fluid out of the arm, compressive wraps to prevent the arm from swelling, and then sometimes pneumatic pumps that patients can wear to kind of push the extremity fluid out and out of the arm. And that's sort of been the mainstay of therapy for many, many years. More recently, we have developed additional microsurgical procedures to improve the lymphatic flow from the arm. And those are things that that I am offering more recently here at the center for patients that do develop lymphedema. There are a number of procedures that we can do to change the flow and improve the flow to help restore that in the arm and reduce the swelling and reduce the symptoms that are associated with lymphedema, which are typically discomfort in the arm, heaviness in the arm. Patients are more prone to infections because of that lymphatic fluid staying stagnant in the extremity. And so we do have some procedures that we can offer, sort of trying to be comprehensive in our care for our cancer patients to address that sort of late stage component of breast cancer that unfortunately has plagued many, many ladies for many, many years.
Very good to know. I'm glad to know that.
Yeah.
So in my case, on a personal level, I had 3 removed on one and 1 on the other. I'm obviously at lower risk, but I still need to be mindful. I do wear my sleeves, especially the one on the left side, like when I'm golfing or in hot weather or hiking or whatever it is that I'm doing. I am told that I can't sit in my hot tub that I just bought back in October past my belly button, and I can't get a wonderful tattoo that I had commissioned that I wanted to put on this side of the arm because that's where the breast cancer side was, and I'm told that I can't do that, or I'm hearing that I can't do that. What are your thoughts on that?
Yeah, we all have had experiences where patients have had minor changes to their extremity that was unaffected by lymphedema that then later developed lymphedema. And so I think the evidence for that comes somewhat from episodes and experiences like that, where we do know that the lymphatic channels on your arm that had the 3 lymph nodes removed is partially injured. So 3 lymph nodes were removed and the flow from the arm theoretically is a little bit less, but it is clearly functioning normally currently at this situation. You don't have swelling in the arm. they don't have any signs of lymphedema. What we're trying to avoid with those types of recommendations is further injuring the lymphatic flow to a situation where it's not sufficient to drain the arm and then would potentially develop lymphedema. So needle sticks, blood pressure draws, any kind of other potential injuries that could damage the lymphatic drainage from the arm are avoided, because the then development of lymphedema can be more complex for those patients. Those lymphatic channels that we talked about do run just right under the skin. So they're very superficial. So that's why things like blood draws and needle sticks and tattoos are recommended to be avoided, because those delicate channels, which are quite small and delicate, do live very superficially in the arm.
I see. That makes a lot of sense. Okay. Hot tub. Those are, like, is that something that
I would say that's
people
not
like
necessarily
me?
a universal recommendation. I have not recommended to avoid hot tubs to my patients. But it goes towards the same concept of not trying to provide any injury to a potentially compromised extremity that is working okay now, but a little damage from some external force might then develop to sort of that threshold to develop swelling in the arm that can be a permanent situation and requires
Oh,
additional intervention.
okay. Very good to know. Thank you. Thank you very much for that. I want to wrap this up by asking you, what is your biggest piece of advice for patients who have just become diagnosed with breast cancer, and maybe even potentially understanding that there might be a surgery in the future?
Yeah, I would think that knowledge is power in that situation, and trying to educate yourself regarding all of the options and choices that you might be facing. Ladies with a new cancer diagnosis are often faced with a barrage of decisions and a barrage of information to take in, and it can be very overwhelming. Um, for that, the reconstruction component of it involves many decisions, as I'm sure you remember from our first consult, and laying out options and discussing future plans and first stage and second stage. But I think educating yourself and providing and gaining that knowledge about what your goals are and what options might be available to you, and becoming familiar with sort of the treatment that might be coming forward in the future, allows you to make good decisions that sit right with yourself and your patient and your own self, and knowing you're made the right decisions, having knowledge of the choices that you have going forward for that. I think education and awareness of the choices, I think patients can make better decisions when they're aware of all of that.
I think so too, because if I had to do it over again, knowing what I know now, which why would I know?
Mhm.
But at the beginning, I probably would have done a little more research, even when I was doing chemo
Yeah.
and kind of looking at the different options that I had. I just didn't have the knowledge enough to actually do that. And so my goal for this podcast is to tell people, look, when you become diagnosed with breast cancer, there are things that you can be researching, and there are options that you can be researching as far as treatments and surgeries, and where you can go, what's available in your own town, and be able to do that research so that at the very last minute, like I actually did, I had these decisions to make very, very quickly, and it was very, very stressful. It all turned out good, but
Yes.
I just want to encourage people to reach out to even people like me and listen to podcasts, listen to other ideas, get on some Facebook, support groups, and listen and try to weed out a lot of negative things.
Mhm.
That was one of the things that I really needed to do, was to make sure that I was sort of filtering out the things that were not serving me in a positive way. And so just the mere fact that you agreed to interview with me on this very baby podcast. I've only have 15 episodes out right now, but it only launched in June. So
We thank you
I'm
for creating it and offering, another avenue for patients to get educated. I can't tell you how many times we see a new patient that come in and say, had I only known what I know now, I would have made different decisions in the past. I
yes.
just didn't know that this was available or this was an option. I would have made different choices had I been educated about, the full scope of what's available for the care of our breast cancer patients or our prophylactic patients.
Yeah.
Any of those situations. I think education and exposure and knowledge is really power, and I think leads to our patients being happier and having better outcomes.
Well, together we can make that happen. I did just think of something. If
Sure.
people want to come to the Center for Restorative Breast Surgery in New Orleans if they want to call and they decide that they want to have surgery, when I made the appointment for my surgery, I was assigned to you and Dr.
Mhm.
Wright. Is this how it always works, or are people able to request certain surgeons?
People, we do take in patients that have specific requests for certain teams, that they may have developed a relationship with in the past or had a personal recommendation from someone else, or based on their whatever research before. Patients can request specific surgeons um, in our practice, and we will do our best to accommodate any of those requests. Again, we have a good number. We're all a team here, so we all work together. Most of our surgeries that are these microsurgical procedures are done with a team approach, so two surgeons working together. So we all work closely together. We all sort of mirror our practices. And one of the benefits of coming to a place like this is you have the collective experience of a group of highly trained microsurgeons who all work together and in tandem together, day in and day out all the time. But as the surgeon, sort of as the lead surgeon that kind of makes the decisions together and works together with the patients, like you and I have that relationship, patients can request to have a specific surgeon being their lead surgeon going forward, and the center will make those accommodations happen for patients that make specific requests.
Well, I will say that I've heard literally nothing bad about any of the surgeons there. Are you aware that there is a support group for New Orleans specifically, and we talk about you guys? So, so it's very easy to see. I'm very blessed that I was able to get you and Dr. Wright. It's very easy to see that you are called you are rated as a top performer in patient satisfaction among physicians in the nation over the last 2 years. So it's easy to see that. Is it more now? Maybe
So
it's 3 years.
I'd have to ask our folks to keep track of all that stuff.
Well, I am so thrilled again that you join me. And to my audience, I do have the Center for Restorative Breast Surgery website in the show notes. That website is just filled with amazing information. That's how I found out a lot about the center, alongside with these three separate people who I spoke to. And there's all kinds of research on there. They can find information on you specifically and see all the picture gallery of the before and afters and all the different types of surgeries. And it's just a wealth of information in there. So I encourage my audience to go into that website. And if you want to reach out to me as well, you can certainly find out more information in my experience at the center with Dr. Cabiling and with Dr. Wright. And so, Dr. Cabiling, again, I appreciate the fact that I
Mm,
know, like, sometimes I text you and I'm hoping that's okay.
of course.
But I feel like we have a good relationship enough where I can ask you questions. And I really appreciate that about you and, the human being that you are and the passion that you put into your work. Is there anything else you would like to leave us with before we wrap up?
No, I just wanted to thank you so much for all the hard work that you're doing to bring awareness and education in your own personal story. Uh, out there. Again, as I started when you first asked me some of the beginning questions, I love what I get to do. It's a great day to go to work every day and take care of the patients and have these types of interactions and see ladies from the beginning where things are scary and hard and difficult out through the end of it where we get to have much more fun conversations about the work we do and kind of getting patients into a much happier position, and it's a privilege to get to do what I get to do. I love it. I'm very thankful that you're able to bring me on and hopefully bring some new knowledge to some of our audience. Yeah, and let people know that we're here. And we look forward to talking with everyone else.
Okay, good. Well, that makes my heart very happy. And
Okay.
to my audience, thank you again. To my audience, thank you for joining us on this episode of Test Those Breasts. And we will see you next time on the next episode.
All right.
Bye.
Bye.
Bye.